Hello, my name is Clint Sheffer. I was lucky enough to be paired with Don Fenton for our clinical project. Don had the great idea of looking into the policies and procedures around blood cultures, blood culture collection, blood culture uh, results, things like that associated with the emergency department. This worked out well, seeing as Don and I both work in the emergency department. We both seen some of the complications, some of the hassles associated with these results that get sent back to the emergency room and some of the problems that can arise from there. In doing so, we figured it'd be a good idea to educate everyone on exactly what blood cultures are, why we would do them, their clinical reasoning, things such as that. So to start off, we have the blood cultures. The reason why someone would have a blood culture drawn. The blood culture is a test that's commonly performed to detect the presence of bacteria or even fungus in the blood. When drawing this test, it's a good thing if you can get at least 2 samples from separate sites. If we have to draw from the same site, you would want it to be about 15 minutes apart. Sometimes you don't get 2 samples if it's children or people who have minimal ways of drawing the blood, minimal sites where you can get it. But typically you would want 2 sites drawn from 2 samples drawn from separate sites. Why would we draw a blood culture? We would get a blood culture to detect the bacteria in the blood. If we can detect the bacteria in the blood, they can grow it, see exactly what it is. It can aid in making a diagnosis if we know the pathogen that's causing the problem. Once we are able to grow the bacteria or fungus, if it may be, but I think it's more than normally it's bacteria, they can perform sensitivities on this to see exactly which antibiotic would be the best to treat the bacteria or infection, whatever that's in the blood. When would we want to do a blood culture? We would want to do a blood culture if someone presents with fever, chills, if there's an overwhelming suspicion for the bacteremia or the septicemia, if you think the patient is septic, following a piercing that shows signs of infection with the swelling and the redness and the drainage. Also, with a rapidly progressing tissue infection, cellulitis, things such as those, it's a good idea to go ahead and try a blood culture just to see what might be going on. Who does the blood culture affect? It affects patients of all age. They immunosuppressed patients are more susceptible, along with those that are debilitated, and the post-operative patients are also at an increased risk. How would we get these blood cultures? Like I said, these blood cultures would preferably be drawn from 2 sites. If you can draw from 3 sites, they're not going to hurt anything. The more samples you get, the more likely you're going to get an accurate result. You would want to draw using aseptic technique. So when you're cleaning the site with the ChloraPrep, you would want to pay close attention to what your syringes are touching, what your needles are touching. You don't just want to lay these things open on the bed or somewhere where people could touch them to contaminate them with anything that may be around. You want to get a pure sample. You clean the site, you let it dry, then we're going to draw the sample, and there's even techniques for getting the sample into the bottles. We're going to pop the caps, we're going to put the alcohol swabs on the top, things such as that. Preferably, you'd want to draw these blood cultures before you start antibiotics. If you already had antibiotics in the blood, you think about it, you're drawing the blood, trying to take bacteria in the blood, and there's antibiotics in the blood, you put it in these culture bottles, the antibiotics are going to work against the growth of the bacteria, which is what we're looking for to have a positive test. If we did already have antibiotic therapy going, we would want to let lab know they do have special culture bottles which they can put the blood into, which as an additive to stop the antibiotics from working on the bacteria as well. These samples are going to be drawn. They're going to be watched for 5 to 7 days to see what grows, if anything grows. Sepsis, blood cultures are the single most important method for detecting sepsis. Sepsis can be defined as a suspected or proven infection plus a systemic inflammatory response. So they're going to be tachycardic, they're going to be febrile, they're going to be tachypenic. These things would diagnose the patient as being septic. More than 750,000 cases of sepsis are diagnosed in the United States every year. 225,000 of these resulting ultimately in death. So this is definitely a problem. There's more than a need for it. The more accurate testing we have, the more better we can treat our patients. Uh, though you're thinking about it, what we can detect from this, all the positives that can come from it, you wonder why you not draw blood cultures. But there are often complications. There can be contamination with drawing these. You can get, more often than not, there's just the normal flora, the normal bacteria that's on the skin. It's on the skin of the patient, or it's on the skin of the phlebotomist that's drawing the blood. There's also a lengthy growing time for these blood cultures. They're sitting in the lab before we can get a true determination of exactly what might be growing in there. There's a lot that can happen in those 5 to 7 days. And in treatment, if you do get a positive result on day one and you know there's something growing but you're not sure what it is, do you go ahead and treat the patient with antibiotics even if you think it's probably a skin contaminant? There's a lot of ifs associated with these blood cultures, especially when you have to consider the false positives. These false positives would mean that we would only have growth in one set. So if you are able to get 2 sets of blood cultures and there's only bacteria growing in one, more than likely that would be a contaminant. Like I said, predominantly it is the bacteria from the skin. So if you do have bacteria growing in just one, do you treat it? Do you consider it's going to be a contaminant? If there's a lot of responsibility laid out there and a lot of leeway, in the docs they're not real crazy about making that call a lot of times. The reporting of these false positives, or the positive blood cultures, not necessarily a false positive, the positive blood cultures drawn from the ER, they're called back to the ER charge nurse, which then places the responsibility on that charge nurse. Now, the charge nurses, they're already busy. There's already enough going on, and they're having to manage the whole department. And now lab's calling and saying, hey, this patient that was here, they're not here anymore, but we're seeing bacteria growing in their blood. So they're passing it on to us, and we have the responsibility of passing it on to a doctor. When we do this, we're going to have to go back, we're going to pull the patient's chart, we're going to have it reviewed by the physician. The physician may want us to call the patient back in. They may want us to let the patient know, call them, see how they're doing, see if they're still running fever, see if they're getting worse. The patient may need to come back to the hospital.